Good afternoon, everybody. How's everybody doing on this last Thursday of October? We only have 2 more months left of this year. I don't know if that's. I remember saying that in September. It feels just last week, but here we are. Let me get.
Last day before election.
It's also true. A lot of lasts this week. So we will see what the future holds for a lot of things. So, Rukia, can you assign me co-host so I can share my screen, please?
Good looking haircut, Deborah. Where'd you get it? I need one.
Don't ask too many questions. I can't tell you.
Okay.
There's no co-host option that I see, but there is, I can make you host.
That's perfect.
Okay.
Oops, wrong button. Here we go. Welcome, everybody. We will get started. I want to leave a lot of time today. We have a really great topic, and I'm excited to hear from both Dr. Berryman and Dr. Blammy for this very important topic about schools and COVID. So I'm going to go through our normal data review and a couple lit review, and then leave the majority of time for this great talk. So once again, last week, Thursday, the numbers revised upward. At the time we pulled the numbers last week, it was about 56,000 or 58,000. When we checked today for last week, Thursday, they revised it upwards to 61,000 today. Our 7-day case average is now at 74,532 for the nation. So once again, the highest it's ever been, looking back at our first and second waves, if we call them that, for the nation. So once again, not a good trend for the country. Our local snapshot for our numbers last week, our 7-day average was 81 cases for the state. Hospitalizations was 10.3 and fatalities just under 3. We increased slightly as a state. Obviously, Oahu continues to go down just a little bit, but the state numbers are kind of increased from Lanai, the clusters in Lanai and also Hawaii Island. Good news is hospitalizations continue to go down and deaths went down. So here is just graphically our 7-day average of new cases. I will take this in terms of it's not a drastic drop, but once again, we're holding steady, and that's a really good thing, and it's a really hard thing to do for a disease that is very exponential in nature, that really likes to either skyrocket or we have to shut things down to get it flat. So the fact that we're at tier 2 for County of Honolulu and we're relatively flat is a good sign. Obviously, this only depicts what it went on the past week. It doesn't depict what actually goes on today. We'll need to find out and see what that looks like in the next week or so. We've had some spikes in fatalities, but once again, that's going to be the most variable of our ladder metrics or our lagging metrics, just because it really impacts drastically the elderly and those with comorbidities. So thankfully for Hawaii, our numbers are relatively low. Hospitalizations, nothing too crazy in terms of spikes, which is good. Sorry, that should be an equal sign. And then current hospitalizations, a mild decrease in overall utilization of hospitals, and especially we like to see the downward trend for ICUs, specifically for COVID, and that's the red bar graph. Percent positivity, once again, continues to trend downwards, which is really good news. And you can see that the testing volume remains pretty constant. Our testing turnaround time this is once again lagged by a week. So this represents on October 18th, the testing turnaround. So it's a little slower, just a tad last week than previous weeks, but once again, way better than the 50% we were seeing a couple months ago. You know, it's really important. We started this look at these 3 states a month ago, and I think it's even more important now as we've opened up trans-Pacific travel, and especially as cases have just nationally in a majority number of states. So Texas and Arizona clearly surge up. And if you remember the past 3 to 4 weeks, California, if they were just holding steady or if they were actually going down. But now, once again, unfortunately, it is clear once again that California is trending. It's pretty clear that they're trending up. Oops. Oh, wrong button. Apologies. So this is a new slide compared to what we used to have. The reason why we added this in is because of the news that earlier this week that we're going to open up to Japan, and now we wanted to at least monitor a little more closely what the trends were for Japan moving forward, as that's going to directly impact us in some way, shape, or form, even though they're bound by the same testing protocols as our easterly trans-Pacific travelers from continent of the United States. So still too early to tell whether or not they're surging or not. I know historically from the news reports, Japan has had reports of under testing. So once again, I'm not sure if they're correct with that issue, but from what it looks like, a slight tick up, but nothing too concerning just of yet. So moving on to our literature review or our science highlights, two articles that I found very eye-opening, especially with this whole discussion of vaccines coming up. So the Imperial College, a really well-known college that was one of the first ones to put out modeling earlier this year, they're conducting many studies in the UK, primarily the REACT study. And I'm going to talk a little about that. And the other study is a survey that looked at factors associated with adults in the United States and how likely they were to accept a COVID vaccination. So once again, as the discussion of vaccines gets more and more relevant and prevalent in actualization, it's important for us to be aware of what the survey says. So from the Imperial College of London, some of the major points to be aware of is that they use a finger prick test. So once again, it's not a PCR test, it's an antibody test. And it's just purely looking at the antibodies in the blood. It doesn't measure the amount of antibodies in a particular person. It is cross-sectional in nature. They do not follow the same cohort and follow them over time. What they do try to do is sample people at different stages of their recovery period to get a duration from just recovered to 2 to 3 months post-recovery. So they have that range of results. What they showed was that over time, there was a reduction of the proportion of people that they tested where they tested positive for antibodies. Now, once again, the limitations, it's cross-sectional. It's not the same cohort over time, but it is, once again, it corroborates what we know about immunity, in that we don't know much about immunity just yet. We're still figuring it out. So it's really, when people say one way or the other that, we have long-lasting immunity or we don't, we just don't have information to draw. Again, is supporting evidence. The other study, and I didn't put a lot of the results. I do want to caveat that if you actually look at the study and really dive in the results, the power and the magnitude of the findings is really not that large. So that's just, I didn't want to clutter the page, but that's just food for thought, that while these are all very clear and may seem very intuitive, the strength of the associations they're not too big in terms of the way they conducted their analysis. But 3 major points. If the vaccine had a longer protection duration, 5 years versus 1 year, then people were more likely to choose to get vaccinated. Another one is a lower incidence of side effects. Once again, pretty intuitive. and then the efficacy, if you increase the efficacy, a hypothetical efficacy of the vaccine from 50 to 70%, once again, you increase the probability of someone choosing to get vaccinated. So not groundbreaking at all, but once again, we need to start somewhere in terms of having concrete survey data, not just hearsay. So, the goal is to build upon this body of evidence. But I thought that these two articles were very important, given where we are right now with the discussions of COVID and vaccinations and understanding who's going to get vaccinated, et cetera. So, and also herd immunity, because that's tied into the vaccine discussion. So I'm going to stop rambling here and see if there's any thoughts for the data portion. We threw in that new slide in Japan, concerns about what we're seeing in the continental United States and whether or not that might transfer to Hawaii. And then also any comments on the two articles that we just shared with you guys today. And we'll spend about 10 minutes discussing this, and then leave the rest of the time for Janet and Tom to share and enlighten us about schools and COVID.
Thomas.
Yes, sir.
I noticed that UHERO, East West Center, and John A. Burns School of Medicine published another brief today, or yesterday, today.
I missed that.
It deals specifically with travel, the risk of travel from Japan. And to their credit, they also analyzed the risk that Japanese visitors would bring the virus back to Japan with them.
Mm-hmm.
And somewhat ironically, the requirement for Japanese travelers or anybody traveling to Japan is to quarantine for 14 days upon their arrival, which kind of doesn't sound too symmetrical, but it is what it is. The thing I wanted to point out was that I don't have the group, but it's a group in Washington that does modeling, and they data that the UHERO authors relied on came from them for Japan and the 50 US states. And the key takeaway for me was that over the next 3 months, starting October 23rd, ending February 1st, that group in Washington forecast a tripling of the number of infected people in Hawaii. So that's out there. And I don't know if that's consistent with what HiPAM forecasting. I know they don't, I've never seen them publish anything that goes out that far.
Mm-hmm. Yeah.
But it's out there, and it seems to have a lot of if it's, it's out there, and it seems to have the most credibility of any forecast. Other people like Dr. Fauci and Dr. Birx have said, hey, you guys got to watch out for the fall, because there's a lot of indication that fall is a prime time for another surge in cases. But that's a lot different than saying Hawaii over the next 3 months, we're going to have the number of infected people.
No, thanks for sharing that. And unfortunately, I didn't have the chance to catch that, but I would definitely look that up tonight. Couple comments from me, and then I definitely want to ping my smarter colleagues in the Zoom call for this. But historically, and I haven't kept up with the methodology from IHME, but historically they use a statistical model, which is a different approach to modeling than the group here, Monique, myself, and Levi, and we more of a different type, although it's still the same SEER, susceptible, exposed, infected, recovered. They rely on more of a black box, so it's really hard for us as outside researchers to kind of see kind of what they do, and it's not compartmentalized in terms of how we approach it. The limitations to and I agree with what Kendry put in these previously in March and April, was that the way they do the modeling relies on actual real data from the location, whether that be Hawaii, California. So if you look early on the response, some of the outcomes for Hawaii was just so drastic because our case counts and hospitalizations were just so small that it was just really hard to extrapolate, and therefore the variance was really wide. And I'm not sure if that's changed, if their approach has changed. So I can't really speak to that until I take a look at that. So that's but I can say for this group, that's one of the limitations
Actually,
that we found. Go ahead, Lee.
I just read that that the IHME model changed from the statistical model to a generative model.
Okay.
I don't know when they made that switch, but they have changed since April.
That's good to know. Okay, so got to do more digging. What I do know, and I can only speak for HiPAM, and I'm glad Monique is here and she can chime in with her models, is that our models definitely focus on Hawaii because we understand how unique Hawaii has been in this situation and will continue to be with our travels and our policies and our demographics. So not saying that IHME is wrong. I think more models are better than, the more models we have, it just adds to the knowledge. But I think I feel confident with what we have and what Monique is putting out. But I will definitely, as a due out for you next week, I will take a look at that report and see, both the IME report, but also the Yuhiro and Jadsam, and that's something we'll discuss. I'll ask everybody else in HiPAM to take a look at as well. Levi, do you want to, before I ask Monique or anybody, Tom, to point in, I know you were working on I'm having a brain fart on a Thursday afternoon. It was you know what I'm talking about, the synthesis of all the models together.
Yeah, an ensemble model.
The ensemble, yes.
So rather than do the actual ensemble, which the CDC are doing, I'm actually just pulling in all of the different models and just showing all of their different projections so we can kind of see where everything's going. So it's not necessarily an ensemble per se. It's just a kind of a directional understanding of where everybody's heading. I don't think that includes it might include the IHME actually within that. I'll have to look to see if that's included there, but that's what we're doing. So
yeah. And then one last thing before I defer to Monique and anybody else. The reason why we only do 14 days for a forecast, like an actual forecast, is because we all know there's so many factors, whether it be policy, behavioral, that can completely impact and transform the transmission of COVID, especially within Hawaii. So, I know IHME updates it, I want to say probably once a week, but if you look historically at what they put out, it actually varies quite a bit. So if you look at what they put out 3 months ago compared to where they have us now, it's really hard to see where they're completely accurate. So once again, that's the limitation of putting something out 2 to 3 months in advance. It's so hard to tell what's going to happen that a lot of times it's a big guessing game when you felt that far. So, Dr. Barron, do you have any thoughts?
Well, yes. I was just pulling up the HiPAM forecast models that are on the website because, and somehow I feel like there's a disconnect between the level of anxiety that I experience minute to minute based on our pre-travel testing program and the rise in tourism and what I see in those models. And so I recognize the reluctance to forecast out further because it's going to change. But I think that when you're forecasting far into the distance, consumers of data understand that the further out you get, the more it's going to change. I mean, there's been a lot of attention to political polling recently. So I think people understand that as you get closer to election day, things may or may not tighten up. But so when I look at those forecast models, and I'm not a modeler, it makes me wonder how you just showed it, the exponential rise on the mainland and what we expect to happen with tourism here, and the transmission that we're already seeing. I mean, Kauai's numbers remain small, but 100% of our cases since October 15th are in travelers, are not quarantined. So that disturbs me, even though the numbers are small. So I think that it might be worth thinking about the balance between the accuracy, the absolute accuracy of the model, and the way in which it's useful for policy and decision makers to look at it.
You're absolutely right, Janet. And one of the ways we've kind of worked around in the past, and with Monique on our team, where we're working on bringing more visibility to her model and her work, is that we're trying to be a little more timely in terms of scenarios. For example, we just worked on something for Halloween in terms of based on historical, what we thought, 4th of July trends and what we hypothesized to be mask wearing compliance. Here's what would happen if we repeated the mistakes of July 4th versus here's what would happen if no one did anything for Halloween, we just stayed indoors. But recognizing that's not likely, here's a probably most likely scenario, and here's a curve, right? And so that's kind of the direction we can do, and we're trying to go through in terms of, without pigeonholing ourselves in terms of this is exactly what's going to happen, more of a scenario based. Here's what probably might happen. Here's the extremes. Here's what most likely will happen based on behavior, and events coming up. So I think we've learned, especially in this group, there's no pleasing everybody. Unfortunately, it's just modeling and scenarioing is an impossible task. But continuing to improve upon it, and I definitely appreciate that feedback, and we'll incorporate that moving forward. But this ties into one of the and I want to be mindful of the time for you and for Tom, but this does tie into the one of the biggest limitations for us for our 14-day forecast is that we still can only rely on the data that we get, and a lot of that data is lagging in terms of cases, hospitalizations, and ICUs and fatalities. And by the time we get that, it's a little, we know there's a lag, so it's hard to get forewarning of maybe if we can kind of tweak our metrics and our inputs, because it's not based on, hard or, forward-leaning data that we could potentially get in terms of maybe some contact tracing information or, how many travelers test positive. But once again,
I would really push back against that.
Okay.
The data that are published are very timely for hospital, except for deaths. But you don't need the hospitalization data, the case data.
Data, of course.
And I think that, my understanding, my very limited understanding of modeling and forecasting is that you're looking at the past and extrapolating what may happen in the future. So it's always an extrapolation. And it's what I'm concerned about, very frankly, with the current modeling is that it gives policymakers a very false sense of security, because the forecast that's shown 3 times a week to the policymakers shows us ticking along perfectly happily at about the same level, as you said, holding steady. Good that we're holding steady now. I think people need to understand that holding steady is exceptionally fragile, and we are doing a lot of things to put it in jeopardy.
Oh no, 100% agree, and I apologize if I wasn't clear. So no, in terms of the timeliness of the data itself is as good as it can be. What I meant was those, but they're all lagging in terms of the indicator we use. Right, we're hoping for leading indicators such as, of the travelers coming in, how many of them were actually tested and tested positive, and how many people are calling the ISOCORE hotline. Those kind of indicators. So, if on our HiPAM website, we kind of differentiate between lagging, which is like our deaths and ICUs, and then our in the middle of the road, which is our cases, and then leading would be, people coming in. That's what I meant in terms of the data that would help us feel better about predicting a slightly higher uptick versus just waiting for the cases to uptick and then we revise it. But I get exactly where you're going. I think a good compromise for now to get those leading indicators would be kind of what Monique is doing in terms of, we're trying to get more timely scenario-based models up and to coincide with our forecasting, so that we can say for Halloween and Thanksgiving, here's what we're going to look like. Here's that sharp increase because we're at a status quo. But if people don't behave well, if they have a letdown, they have COVID fatigue, all it takes is that, and here's that exponential rise again. So we're working on getting that onto our landing page to give people that short-term kind of look, but also a month to 2 month based on what's coming down the pipeline for events and holidays, etc.
Not to belabor it, but can I just ask, I mean, the data that you showed for states on the mainland for cases, are you looking at tourism authority? Do you have access to tourism authority data that tells us where travelers are coming from? And are we connecting those dots? You know,
so I just had a great meeting with Monique yesterday. So we're growing our team. So we're starting to do deeper dives. And that's one of the things we're trying to look at, which is HTA data, DBED data in terms of travel volume, where they're coming from, and eventually linking that hopefully with cases, because her team is definitely pulling data from DOH in terms of zip codes and where the cases are popping up. So but thank you for that. And because you're one of our presenters, I want to make sure you have enough time for your presentation and also for Q&A. And I really appreciate this super good discussion, because it's, I feel like we've had this discussion in the past, which I think with COVID, it feels like it's just yesterday, but I know it's happened in the past. But with that, I will reshare the screen, and I'll be your Vanna, and I'll kind of go along the slides. So just let me know when.
Oh, okay. I was going to be sharing. Okay. Thank you, Thomas. Thank you for asking me to do this. I feel very much out of my depth doing any presentation to a data group, and you will see that this is not a very data heavy presentation. I'm going to leave all that to Tom, who I know is going to take it away. And I also have to say that these are, oops, back to the beginning slide. These are not my slides. Sarah Kemble and her staff, Karen Ng, prepared this presentation for a variety of audiences and have lent it to me, and I've selected a few slides from there. With regard to the conversation we just had, I just want to say that I like everything to be data-driven, including my anxiety and what keeps me awake at night. So that's why I'm asking for so much information about the forecasting. So I'm just going to go really quickly through what the current guidelines from DOH for DOE are. These guidelines came out of very long and impassioned and involved discussion and back and forth. And they were changed when the CDC came out with new guidelines. And they remain guidelines. They are not, and recommendations, they are not proscriptive. They are advisory to the Department of Education, and within the Department of Education, that handled through the superintendent and the complex area superintendents in terms of how they actually decide to use or not use or adapt these. And they're applicable to all schools, not just all schools, and private and charter schools were involved in the development of them, not just the DOE schools. So next slide, you can just pass over it because I think all it says is thresholds. So in this latest version, which I'm going to share with you, we really, Dr. Kemble really we used the City and County of Honolulu's recovery framework as a starting point, because she and I and Dr. Char were all very involved in the development of that. And some of the questions of where are you going to set the thresholds and where are you going to be more worried and less worried seemed like they were parallel conversations. There was no need to entirely have them again or start from scratch, and that there was also some advantage to having a level of alignment between what the city and county is doing and what the school recommendations are statewide. And there's also some movement, as you may know, for other counties to adopt similar frameworks. Kauai has, and Hawaii Island is looking at it. And what we were trying to do was give people a consistent guideline for thresholds that would be a trigger for changing the learning models. And the learning models, as you may know, are all in person or a blended model, which can mean a whole lot of things, but where there's some traditional in-person learning and some online learning or alternating days or whatever, to a completely remote learning model. And there was also attention to the importance of education and the importance of in-person education, with the thinking being, and the Academy of Pediatrics was involved in this as well, but the thinking being that in-person learning is particularly important for younger children, and also then looking at the risk of the school setting where younger children can be in relatively small groups, which are relatively self-contained, so there can in essence be a school bubble of a sort if you pay attention to it. Whereas as you move into middle school and high school, where students are older, are more independent, are typically changing classrooms frequently and recombining in different groups all day, socially as well as academically, it's much harder to maintain that kind of exposure control. We also had a lot of discussion about just how to identify the metric that we would use to identify the thresholds, and what we decided to go with was the 7-day average rate per 7-day average of new cases per 100,000 population. And by expressing a population rate in that way, it makes it a little bit more transparent how to apply it to the various counties, or if a large county like City and County of Honolulu wanted to go to a smaller unit, they could do that and still base it on population parameter. And then, as was done for the City and County of Honolulu, in addition to looking at the 7-day average case rate, there's a secondary measure of the percent positivity of testing. But because, as I know this group is well aware, that positivity rate, one, because there's been a lot of discussion about how to calculate it, I think we've settled on a methodology, but beyond that, it can be impacted by a lot of things. So it can be high county-wide because of a very localized outbreak, or it can be very low because there's been a big testing effort in some area that didn't wind up having a lot of disease. So it's a secondary measure, not a primary driver. Next slide, please. So these are the thresholds, again, expressed as a daily average cases per 100,000 population, and then the percent positivity, and then the 5 suggested types of learning. So in the green zone, where there are very few cases, it's all in-person learning is recommended at all levels. In the yellow zone, where there are more cases, in-person learning is recommended for elementary students for the reason that I just said, but blended learning, a more cautious approach to secondary school students, meaning middle and high school. And then in the orange zone, an intermediate level of cases and percent positivity, blended learning for all students so that all have some protection but still get some of the benefit of in-person learning. And onwards, at the red level, where there's quite high level of transmission, blended learning for the elementary students, so they still get some in person, but are remote learning some, and the secondary students, for reasons I said, are all learning remotely. And then at the highest level, everyone learning remotely, everyone learning from home. I was going to say something about that, but it just went out of my head. So the 7-day average per population rate, I'm sure it's easy for all of you. It's not necessarily the easiest metric for the general public to consume. It is, however, easier than the 14-day total number as a rate per 100,000, which was another thing that we looked at, which caused me to stumble in my brain as well as saying it out loud. But if you think that, Oahu has approximately 1 million people, then you can see that that the green equates to 20 or fewer cases a day, the yellow to 20 to 50 cases per day, the orange 50 to 100, and so on. And those, these divisions are not heavily science-based. They are really based on our experience to date, and in particular, Dr. Kemball's observation of how and when the Department of Health's contact tracing capacities have been stressed and overwhelmed by prior levels of cases, and the capacity that we currently have that we didn't have back in August, and what that might enable us to manage. And there's also a recognition that schooling is, from a public health perspective, a higher level priority than many other things that we do. So these things are slightly different from social gatherings, or when we would recommend travel, or when we would, allow there to be large concerts and things like that, because of the rationale that education is a critical function and a critical activity for our youth and for their parents who need to go to work in a way that some of those other social things are not. Next slide. So this is a lot of words, but basically we wanted to be clear with the schools that we're not saying that you should change what you're doing every 7 days, that we understand that that would be completely disruptive to everybody. So recommending a minimum of 2 weeks of the data being in the next tier that you're looking at going to before you go to that tier, whether you're going backwards or forwards, basically. So that raised the issue of, well, maybe we should look at a 14-day average rather than a 7-day average. But we decided that looking at 7-day averages allows you then to say, this 7-day average is trending in a direction that either we do like or we don't like. So another week from now, if we see the same thing, then we should be preparing to change. So it gives the schools a clear intermediate step to look at, rather than obligating them to think about it midway through a 14-day period. Next slide. The same thing, next slide. And so this is an example of how one can apply this. So looking at basically the first 2 weeks of October, so this was done a little while ago, and looking at the 7-day average daily cases for each island, because Maui County needs to decide by island, and looking at the % positivity rate for 1 week and then for the subsequent week, and then using the model that's summarized there across the bottom, what learning model would each county or island be in at that point. And so you can see that if we were using this for the first 2 weeks in October, Hawaii and Oahu would have been in the blended learning for everybody model, and Maui, Molokai, Lanai, and Kauai would have all been in all in-person learning. So of course that has changed dramatically for Lanai since then. But I did look at the numbers for both Hawaii and Oahu, and I believe that they still remain in that, in what would be the orange zone. So that's how this would look applying it in person. And I think that's the last substantive slide. The next one is just my email address and mahalo, and I think you all know how to reach me anyway. Thanks.
Thanks so much, Janet. I will, in the interest of time, move to the next slides, and I believe, Tom, you are up.
Yeah, so thanks, Janet. Janet and I talked briefly, but I really didn't know where to start exactly. So I just tried to gather some data, and it's interesting, right? So the metrics are, most of us don't know this, but and I talked to a couple of principals here in Maui. So it's kind of up to them, right? Even though we're open, Maui's open, it's suggestive. It's not, you still, decide what you're going to do. And it was interesting to drill down a little bit. And the principal, once I asked him kind of specifically, they have certain faculty, and a lot of the faculty aren't that young. And if they pressure them to come back, they would lose some faculty, and they can't afford to lose faculty. So a lot of the schools are going to stay fully online. So I don't know if everybody's already aware of that. I really wasn't. So I just put together some data slides just for talking points for all of us. And obviously, to broach the other conversation that Thomas and Jen are having, we really don't have, we have reported data, but we don't have a lot of leading indicators, right? So, and we don't have a lot of depth and different variables and levels of these variables to try to build really creative models. So it's kind of an interesting experience we're going through. People are holding data rather tight, and probably for good reasons, right? But we are where we are. And model. So that's great that some of these models are going ahead and forecasting out a month, 6 months, 10 years, whatever. The answer is they're wrong. The real answer is, how wrong are they? And yeah, so UW had a model fit in the original days, because whoever the statistician, epidemiologist, whatever their background is, that's where they're going to start from. And the UH or UW group started from a statistician that was his background, statistical modeling. So he fit the model. And then once he gathered more experience, or the team gathered more experience, like, hey, listen, let's let's do some sort of ensemble. I think they're calling it hybrid or varied or whatever. And then if you dig down to the UW model, they say, well, you know, we're doing a piecewise kind of thing. At some point we'll do an SCR, SIR. At some point we'll do a model fit. At some point we'll do, you know, an exponential. So it's not really as clear as anyone would love it to be. So here we have a slide on, let's see, daily cases per 100,000, like we were talking about as a metric, and reported for the months for the different counties. And I know that, you know, in our breakout groups and our subgroup modeling group, we like to try to blow into a lot of these. I know Esteban likes to do some log modeling and try to look at that little tip. And I know Lee does too. Like, what's that little tip at the end telling us? Right? Does that mean going straight up? What's that going? So you can see Hawaii is looking like it's going up, right? Because all you need is a super spread sniff for this to happen. And that's what we're seeing there. Maui's been pretty flat, right? Except that doesn't include the latest kind of super spread on Lanai. And I think it came out of, I think we were talking about this, it was a funeral, right? That was the event that spiked Lanai. Okay, so in Honolulu, obviously you have a much bigger denominator, so it's much more stable. Kauai's been, you know, really conservative. Does anybody else have any? And here you have some metrics, right? You have your Hawaii, your Honolulu for 7-day average. Does anyone have any comments? Because this is really a team. I'm not some guru here for the ed. I'm just trying to pull up some data to talk about. Does anybody have something about the slide they want to talk about?
No, I think
I have a question.
Oh, go ahead, this one.
I'm sorry.
No, go ahead, this one.
Do you know what outside Hawaii means? In, you know, there's a fourth category or fifth category in these spreadsheets outside Hawaii, and it has started to grow a lot after October 15th. And I was wondering whether that has to do with travel coming up, because my hypothesis was that, you know, it's hard to see the early effect of travel, say in Honolulu, because already we have a lot of cases, so a few cases will not show up, but something that is very low does show quickly an increase, and that category just shot up exponentially since October 15. So what does that really mean?
I can speak to that a little bit, Istvan, very briefly. Hawaii residents who are diagnosed elsewhere are in that category. And in general, that's people who spend their entire illness outside of the state, so they don't pose any risk or reflect anything about our state. But the very interesting, I think some unanticipated, although it was anticipatable, impact of the pre-travel testing is that Hawaii residents who travel to the mainland and get a pre-test before returning home, some percentage of those are turning up positive, and then they are not able to come home. They need to serve out their isolation on the mainland. So that's actually a very good thing for us. Those are our residents who travel elsewhere, get infected there, but they're not going to come home until they're no longer infectious. I'm not sure how that fits into the model, but it's a fascinating observation, and I'm glad that you picked up on it.
Those would be really great leading indicators, actually, right? I mean, there's small numbers, but they're really indicative of what we'd see from many of those populations that are traveling here, that we wouldn't have those tests otherwise, right?
Yeah, we wouldn't have those tests otherwise, but I don't know how valid it is to assume that our residents going on vacation or to visit family in the mainland have a similar, you know, exposure risk as residents of the mainland who are coming here for holiday. But
it's not exactly homogeneous, but it's better than nothing.
Right, it's all wrong. It's just a question of how wrong.
All these exactly how messy is your leading indicator, but at least you have a leading indicator, right? Esteban, is that good?
Yes, thank you. That's good. Yeah, I just wanted to know what exactly that really means, because we were discussing that and people told me exactly what Janet was saying. So Janet confirmed that this is what it means. But it's an interesting indicator, and it does look clear that it has to do with travel because it shot up after the 15th. But it's interesting. Thank you.
Yeah, it sounds like, Thomas, that Lee posted had curve fit on this that he just did. Since we're here, we could pop it.
Talking about the thing I just posted?
Yeah, Lee, that's what you're talking about, this data, right? You just did
Yes.
some modeling? Okay. So I think
So
Thomas can click.
at least in the aggregate for Hawaii, it doesn't show an uptick yet from the travel permissions.
Sorry, here we go. There we go.
So Lee, you want to talk about your crazy graph?
Yeah, so this is taking a least squares fit of five periods of exponential growth that can be positive or negative, and this is what you get. So the green line is the exponential growth mean. The blue line is the actual case numbers, and the orange line is when you take the green line and multiply that by this day of the week factor, which boosts the Wednesday through Saturday numbers and depletes the Sunday through Tuesday numbers. And that's what that orange line is. And so projecting that out for the next 14 days, we see, you can see that on the far right of the graph. So that's what that funny zigzag thing is. But it's kept consistent since early September of a exponential decline with a 2 to 3 month half-life period. And that's really not changed in the past 2 weeks. So that seems good to me, a good sign to me, but who knows what it's going to do in reality in the future.
Right, the lags, right? The lags that Thomas was talking about. Do we see them in there, right? Or all of a sudden we're going to see this spike straight up, right? And Janet was discussing either how sensitive our community is to, an event, right? Especially in the outer islands.
Well, I would say sensitivity is the fact that RT is very, very close to 1. It's a little bit below 1, which is why we're getting this 3-month half-life. But just a slight change in the activity would boost it above 1, and then you have exponential growth. So we're at the very sensitive point in terms of how it responds to people's behavior.
Yeah, we've been pretty good. It's been really impressive, right? I don't know how it's going to be. We had the Pack Islander issue, and then we did great. DOH, everybody did a great job there, and everybody got, on board there. And so, but yeah, this travel thing, I just don't see how we would be any different, right? It's going to be less, right? But we're going to get some, and we talked about this, I think, Tuesday. We're going to get some people that come through with false negatives, and those people will have some impact. So what that number is going to be, we will see. Yeah.
We're also going to get people who test positive, and because they've tested positive, they just don't reveal their test and they fly anyway. We've already had that experience.
And then they say they're going to quarantine and don't. So just
exactly.
Or they mingle in the airport, and we have those issues.
All of the above.
Janet,
they hold a campaign rally.
Janet, I have a question since we're on this vein, and Tom, I apologize for hijacking this, but
no, that's great.
So thankfully we had a great presentation on the schools. So at least I feel good that we talked about that. But one of the great things about HiPAM is we kind of figure out where we're going to go, and then it kind of evolves, which is a great thing. So you mentioned, because this does tie into modeling, and because the people's behavior kind of it helps us better understand what to expect, because it's not just about sensitivity and how accurate the test is for people coming in. When it's not true that we're assuming everybody's going to follow the rules. So from what you've heard, Janet, I know that right now you just the traveler would just upload their negative test onto Safe Travels Hawaii. Is that correct? There's supposed to be verification, right? Because it's supposed to be from a trusted.
Oh, there's verification. It's not working smoothly. It's supposed to be handled by the app, by the AI system. Don't even get me going. But there are so many trusted partners, and they report their labs in so many different ways that it's extremely challenging for the automated system to do it. So there's a lot of manual verification that, but even the manual verification, you know, it would not at all be rocket science to create a fraudulent.
PDF.
Our IT guy did it in 5 minutes 2 weeks ago and ran it through the AI, and the AI was totally happy because it only had the essential elements on it, nothing else, nothing to distract it. It was perfect, but it was totally made up. And he's selling them online. No, I'm kidding.
Well, I mean, so I mean that's good to know for everybody here as we're working on our models that, you know, we have to account for human behavior, right? Not just for our local populations for mask wearing and not gathering, but for our tourists, but also returning residents, because understanding people want to come home and people invest all this money to come, that if they're mildly symptomatic, they got their negative test first, and then we understand the timing, they get a negative test, then one or 2 days later prior to travel, they have symptoms, they're going to take Tylenol, ibuprofen, whatever they need to do to hide their symptoms, and they have the negative test, so they're going to come in. And so just, you know, and it's virtually impossible to model that out, but it's something we can account for in terms of some variability. But that's good to get some verification, Janet, that while there's a lot of positives, there's still some, you know,
right,
rough patches.
But even more importantly, we know that a test on whatever day is not going to pick up people who were exposed 48 hours before that, or any exposure that happens between then and when you arrive here. So I think if you know the population prevalence from which you're coming, you can model out by the day of testing how many days of exposure and apply that prevalence to that population. And we know inherently we are not going to pick those people up. And that's what I'm interested about, is that being included, and those people then transmitting disease with whatever RT makes sense. And does it apply, you know, should the RT for tourists be the same as returning visitors? It's probably different in actuality, but
yeah, for sure. I want to bring Monique in because we just talked about this very issue. You know, we were getting pretty deep into the weeds in terms of, you know, probably, you know, putting people in different compartments in terms of the day that they got tested. But we realized, like you said, Janet, that the most important thing is what is the prevalence of COVID from which they're originating, and we're creating another rabbit hole if we go state by state. So the way that we did it earlier this year in June, and I think how we're going to approach it moving forward again with Monique's modeling, is just to take it for the nation, because there are groups like Imperial College and a couple others that we're sourcing that estimate the prevalence for the nation. Take into account that what's reported is probably not the actual prevalence, so you know they're factoring it and then using that as an estimate, and then applying the sensitivity of the PCR, et cetera, to get those who would be missed. But Monique, do you want to add anything before, you know, once again being mindful of the time, if there's anything you want to add to this talk, because I know we discussed this yesterday.
We also spent like an hour just before this with the students and with this and discussing exactly that. So it is a non-trivial question, right? And we're trying to find the in and out, and the students are going to now work on it. They're going to do some simulation. We're going to see if that makes sense. Again, the idea is we're not going to be able to make prediction or forecasting. We're going to be able to make simulations and scenario, right? And then we can see how the wave are impacted and how much like relative error, or like how much of a bumper we have before we get exponential, or that's the kind of answer that we can have. We're not going to be providing any quantitative measure of like how many people we can handle, because that's just, the model cannot do that. And then regarding the models, I think a lot of models are extremely good. It's not the model, is how you use it. And this is really hard. I think COVID has shown that using properly a model is very complex. And and that's what everybody is trying to do. Yeah, what can I say? Different models look at different things, but again, like our choice for my team was to use a model and to target it for Hawaii. So we cannot transpose it as is to other states. We would have to do some backward, like some work, etc. That was the option that we took. If you take like the perspective to have a model that is transportable, then it's a different approach. All approaches are valuable, and I think we're learning we have to do all of them and work together.
Thank you so much, Monique. Hopefully that for I see a couple of new names, and hopefully for everybody joining us, whether you're regular or new, what Monique said just now really captures the essence of modeling in terms of what it can do, its limitations, and the purpose that it can have, not just from an academic setting, but to influence in a positive way decision makers and policymakers, so they understand that it's, you know, we can have some impact, but it's also not meant to be a crystal ball. Unfortunately, the only crystal ball we have is we're dealing with COVID for a while longer. That's all. That's, I think everybody can agree with that. And with that, I want to thank everybody. I apologize I didn't get to call on everybody because our group is growing, which is great. Next week we have Marguerite, who I don't believe made it today, but we're gonna have a treat for the next couple of weeks. We're gonna get a little nerdy, but don't be afraid. It's not gonna be, if I can understand it, I think everybody else can, but we're gonna take a slightly different direction in terms of a more hard science. We learn some about potential uses of the scientific technology in terms of using genetics to kind of figure out the path of COVID and maybe as a new screening tool. So I requested that they provide a dummies guide because that's something definitely I need for that field. So look forward to that next week, Thursday, in addition to our normal data updates. With that, please be safe. Have a happy Halloween. Watch a scary movie, stay inside, or just stay inside if you're like me, because I hate scary movies. Eat some good candy, and we'll see you guys next week, Thursday. Thank you, everybody, for your participation.
Thanks, everybody.
Thank you, guys.
Thank you.
Aloha.